Hello everyone and welcome to this webinar presentation, Leveraging Non-Invasive Approaches in NAFLD, NASH Diagnosis and Clinical Research. My name is Christy Calloway and on behalf of ALPCO, I would like to welcome you all to this webinar. ALPCO is a leading provider of assays and other testing solutions. We're committed to supporting scientists and healthcare professionals with resources that promote the advancement of research and improvement of patient outcomes. I have the pleasure of introducing Dr. Sabina Paglialunga. Sabina is a metabolic and pharmacodynamic specialist at Celerion. Celerion is a full-service clinical research organization which specializes in phase 1 and 2 clinical studies. Sabina joined Celerion in 2015 in her current role, provides scientific and operation support for early clinical studies with an obesity, diabetes, or fatty liver disease indication. Dr. Paglialunga draws upon her over 10 years of research experience. She holds a PhD in biochemistry from McGill University in Canada and has completed 3 postdoctoral fellowships concentrating in lipid metabolism and glucose homeostasis. She has an extensive background in metabolism and fatty liver disease. Now, without further ado, I'd like to turn this over to Sabina. Welcome, Sabina.
Thank you, Christy. I would like to thank the ALPCO team for inviting me to participate in their webinar series. As the name implies, non-alcoholic fatty liver disease, or NAFLD, is a chronic metabolic disease not associated with excess alcohol intake or viral infection. Steatosis, or fatty liver, occurs when lipid deposition exceeds 5% or more in the liver. Non-alcoholic steatohepatitis, or NASH, is associated with hepatic inflammation and injury, and extensive fibrosis can lead to cirrhosis development. NAFLD is an overall umbrella term for the histological characterization of the disease and is the most common cause of chronic liver disease in the U.S. NASH is anticipated to become the leading indication for liver transplant by 2020. The following is a simplified illustration of the pathogenesis leading to liver fibrosis. Adipose tissue dysfunction and increases in free fatty acids, as well as dietary fat and newly made fat from de novo lipogenesis, can all accumulate within the liver, causing hepatic steatosis. Insulin resistance, as well as increases in oxidative stress and pro-inflammatory cytokines like TNF-alpha, interleukin-6, CRP, and downregulation of anti-inflammatory cytokines such as adiponectin can induce lipotoxicity within the liver. This drives ER stress, apoptosis, necrosis, and inflammation, resulting in the development of fibrosis. Approximately 25% of the general population has fatty liver or steatosis, and this is related to the growing incidence of type 2 diabetes, obesity, and metabolic syndrome. Of those with fatty liver disease, 60% will develop NASH. And NASH is characterized by steatosis, lobular inflammation, and ballooning injury. 30 to 40% will progress to fibrosis and cirrhosis, which can lead to hepatocellular carcinoma and end-stage liver disease. There is a small percentage of subjects with NASH independent of fibrosis that may develop hepatocellular carcinoma. The exact prevalence and cause still needs to be elucidated. Risk factors associated with liver disease progression include type 2 diabetes or a family history of diabetes. Approximately 70% of type 2 diabetes patients have fatty liver. Metabolic syndrome and its components such as hypertriglyceridemia and obesity, recognized as increased waist circumference, are also involved in liver disease progression. Advanced age is another risk factor, as well as certain ethnicities, such as the Hispanic ethnicity, which has a higher incidence of metabolic syndrome and predisposition to certain genetic factors, such as the PNPLA3 variant. This gene has a role in triglyceride remodeling and fibrogenesis. Current NASH management strategies include weight loss, exercise, diet, gastric bypass, and vitamin E. And it is important to note that there is no approved treatment for NASH. Therefore, 7 to 10% weight loss is recommended. Both aerobic and anaerobic exercise has been shown to be effective in resolving NASH, as well as the Mediterranean diet, which focuses on eating plant-based foods such as fruit and vegetables, whole grains, legumes, and nuts. Reducing fructose intake and alcohol intake is also important. For the obese population, gastric bypass may be prescribed, as reductions in fat liver content here has been shown to improve the histological features of NASH, as well as increase insulin sensitivity. And there is some data showing an effect of vitamin E in NASH resolution. However, there are cardiovascular safety concerns over long-term use. Therefore, drug developers are targeting the underlying factors, such as the metabolic syndrome factors, as well as the components of NASH for treatment. So there are a number of anti-obesity and type 2 diabetes medication, as well as anti-steatotic drugs, which inhibit the lipid synthesis pathway, drugs targeting inflammation or apoptosis, and antifibrotic drugs in development. And right now, there's currently over 100 therapeutic agents in clinical trials. The majority of these drugs are in early phase development, and while there are a few in late phase, results from these studies and approval are not expected for another few years. From a medical standpoint, NASH is asymptomatic. Patients will often have nonspecific complaints, such as fatigue, abdominal discomfort, feeling of full, and only 50% will have elevated liver function enzyme tests. Swollen liver is also only seen in cases of advanced fibrosis. So the reference standard for diagnosing NASH is through liver biopsy and histological assessment. The NAFLD activity score, or NAS, has 3 components: steatosis, lobular inflammation, and ballooning injury. A value of 4 or more is a diagnosis of NASH. Fibrosis is not a component of this score, and NAS is not validated for cirrhosis progression. Fibrosis staging, on the other hand, qualifies the amount and pattern of fibrosis and progression towards cirrhosis. There are 4 stages for fibrosis, and typically progression is 7 years per stage. There is a group of rapid progressors that can develop cirrhosis within 10 years. Clinical endpoints for intervention studies include a reduction in the NAS score, resolution of NASH without worsening of fibrosis, and improvement in fibrosis stage without worsening of NASH. The liver biopsy, however, is not a feasible long-term approach for managing this disease. It is an invasive procedure with low acceptance patient rates and risk of complications. The biopsy portion represents only 0.002% of the entire liver and can be afflicted by sampling error and interoperational variability. Liver biopsy is also not suitable for all patients. Currently, it's only recommended for those at risk of NASH with advanced fibrosis, or if AST and ALT are elevated but a diagnosis is unclear, and prior to enrollment in a registered clinical trial. This is where alternative approaches are needed and the biomarker comes in. A biomarker is a defined characteristic that is a measure of a normal process, pathogenic process, or response to a therapeutic intervention. And the ideal biomarker is clinically relevant. It's related to a clinical endpoint or drug mechanism. It's sensitive and specific, able to detect changes within a target population. The ideal biomarker is reliable, it's analytically good with strong accuracy, precision, robustness, and reproducibility. It should also be practical, non-invasive, and suitable for multi-site use, and simple. The simpler, the better for translating from the bench to the bedside. The ideal NAFLD-NASH biomarker is able to distinguish between fatty liver versus no steatosis, definite NASH versus not NASH, and no or mild fibrosis versus advanced fibrosis. There are a number of alternative approaches, including ultrasound, magnetic resonance, elastography, and soluble biomarkers that are able to examine hepatic steatosis and fibrosis, or both. Ultrasound is a widely available first-line diagnostic tool in a medical setting. The results are more qualitative than quantitative, and fat liver content must be over 30% for sensitive results. Ultrasound has limited fibrosis detection and is influenced by body size and is not appropriate for clinical studies. Magnetic resonance is a more sensitive method. Here, hydrogen atoms from water and fat have different properties under a magnet, and we can compare a lipid signal to a water signal. There are two modalities, magnetic resonance spectroscopy and magnetic resonance imaging. MRS is the gold standard for steatosis. It has excellent sensitivity and specificity. However, this method is quite expensive and not widely accessible, technically difficult, and available only in specialized research units. Magnetic resonance imaging with proton density fat fraction acquisition offers good spatial coverage of the liver and is widely available in hospitals and liver clinics. These two modalities were compared in a head-to-head study as a secondary analysis of the Soluble trial, a cholesterol-lowering agent. Here, 50 NASH subjects underwent magnetic resonance evaluation with a paired biopsy. In the left panel, we see that the percent fat determined by magnetic resonance spectroscopy on the y-axis strongly correlates with percent fat determined by magnetic resonance PDFF on the x-axis. On the right, here we show that there is a similar separation among the histological staging of steatosis for MRI-PDFF on the top panel and MRS on the right, on the bottom. This study therefore provided supportive evidence to incorporate MRI-PDFF over MRS in current clinical research studies. Elastography determines fibrosis as a function of liver stiffness. Here, a low-frequency shear wave is mechanically induced and propagates through the liver. The generated velocity is proportional to liver stiffness. Liver stiffness can be evaluated with magnetic resonance elastography, in which an external acoustic driver system is used to propagate the mechanical wave as the subject is in an MRI scanner, or with transient elastography in the case of the FibroScan, which uses a handheld probe to generate the wave and measures echo. A comparative analysis was recently performed in 142 patients, 34 with fatty liver, 108 with NASH, and 10 BMI and age-matched controls. The top panel shows that both magnetic resonance elastography and transient elastography show a good stepwise increase in fibrosis stage. In the bottom panel, we have the receiver-operator characteristic curves. Here, these graphs plot sensitivity against specificity compared to a reference standard. An increase in area under the curve equates to better performance against the reference standard. The rock curves show the performance to distinguish liver fibrosis from various stages. MRE shows high sensitivity and specificity in distinguishing advanced fibrosis stage from mild fibrosis stage. The following table summarizes the merits and limitations of these modalities. As I previously mentioned, ultrasound is not robust enough for clinical studies. FibroScan with the CAP feature can measure both steatosis and fibrosis simultaneously. And there is a trend for PDFF over magnetic resonance spectroscopy. Common limitations associated with these imaging techniques is the requirement for specialized equipment, the technical staff, and sophisticated analysis. And that's where we can leverage soluble biomarkers as a cost-effective tool. Consider the soluble biomarker as a liquid biopsy, where pathophysiological concentrations of hormones, cytokines, or metabolites can be measured, all related to fatty liver disease. This is easy to implement in both the medical and clinical settings, and combining various biomarkers can increase the sensitivity with composite biomarkers. The following biomarkers listed here are all related to the pathogenesis of NASH, where we have biomarkers for oxidative stress, apoptosis, inflammation, and fibrosis. And I'd like to highlight CK18, caspase-cleaved CK18, and the role of adipokines in NASH. Cytokeratin 18 is released from damaged cells during cell membrane integrity loss. The fragment is cleaved by caspase 3, and this biomarker is currently recommended by the FDA and the American Association for the Study of Liver Disease as a secondary endpoint of biomarker cell injury in cell death in clinical studies. A cutoff value of 270 is associated with a definite NASH diagnosis. However, this biomarker has limited diagnostic value for fibrosis. And that's where composite biomarkers may provide better accuracy. Composite biomarkers listed here are a combination of demographic factors as well as simple blood tests. Many of these composite biomarkers were derived for fibrosis assessment with viral hepatitis patients. And cutoff values have been validated for NASH subjects. The area under the curve for these biomarkers range from 75 to 85% when compared to subjects with advanced fibrosis For steatohepatitis, there are a number of NASH composite biomarkers using anthropometric data as well as cytokines and hormones such as interleukin-6, CK18, and adiponectin. These biomarkers all have good sensitivity and specificity, as well as a high area under the curve. And I'd like to highlight a promising biomarker here, the NAFLD and NASH discriminating score, which uses adiponectin, TNF-alpha, cisplatin, and interleukin-6. Here in 54 control subjects and 54 NASH subjects, we are able to show a 94% area under the curve for NAFLD discriminating score and a 90% area under the curve for the NASH discriminating score. In conclusion, there are a number of challenges facing the NASH indication, which includes the no validated surrogate non-invasive biomarkers, no approved treatment, varied success with current management strategies, the need for liver biopsy, and the limited availability and high costs associated with imaging methods. This is a large opportunity for soluble biomarkers, which can be used for diagnosis, distinguishing between stages of liver disease, and the assessment of a treatment response. And then partnering with a bioanalytical expert or key opinion leader could help with meeting your study needs. Thank you. And I'd like to turn back the presentation to Christy.
Thank you so much, Sabina. That was a very insightful presentation. I'd just like to reiterate that we at ALPCO are really at the forefront of providing solutions to advance NAFLD NASH research, and we have a number of assays, including these listed here, that are currently being used in this space. We have a plethora of resources on our website for further information and resources. We have a NASH NAFLD brochure, research spotlight, and an ebook available for download. If you have any questions regarding any of our products or this presentation, please feel free to reach out to me. My contact information is listed here on this slide. Now, I would like to open up the Q&A section. We have a few questions here. Our first question, Sabina, is, are AST and ALT sufficient for early NASH detection?
Thank you, Christy. So no, they are not sufficient for early NASH detection. As we saw, only 50% of NASH subjects actually present with elevated AST and ALT. However, it is important to track these because they are associated with advanced fibrosis. So they become, I think, more important later on in the progression of the disease.
Thank you. We have another question here. What is the greatest challenge for treating NASH?
The greatest challenge right now that we face is the need for biopsy. We need to have validated surrogate non-invasive endpoints to advance and accelerate NASH treatment. Ideally, it would be great if we had something akin to the type 2 diabetes or diabetes indication where you have hemoglobin A1C as an endpoint.
Thanks. Our next question is, which biomarkers do you recommend?
Well, that really depends on your research question and the context of use. So right now, there's a lot of really good sensitivity and specificity being shown with the composite biomarkers. So my recommendation would really be towards one of those composite biomarkers, depending on what your research question was.
Okay, now speaking about biomarkers, biomarkers are validated against the imperfect biopsy scoring. Shouldn't non-invasive biomarker rather be validated against hard outcomes?
Yes, most definitely. And hard outcomes for NASH include cirrhosis development, hepatic decompensation, and mortality. The only thing is these take years to develop, and we don't have enough information on these biomarkers in the natural history of the disease. So unfortunately, for now, we just have our reference standard, the biopsy, for this information in validating our biomarkers. But eventually, to advance the field, and there are certain biomarker consortiums working on this, we will be able to have soluble biomarkers validated against hard outcomes.
Excellent. Thank you so much, Sabina, for presenting this webinar. It was a pleasure to have you, and we really appreciate your time and sharing your expertise with us. As I mentioned,
Thank you so much.
As I mentioned earlier, this presentation as well as other resources are available on our website. Again, if you have any questions or would like more information, please feel free to contact me. My email is ccalouette@alpco.com and is also listed in this presentation. And thank you again, Sabina. That concludes this presentation.